Two patients can both be 70 years old, undergo the same operation, and leave the hospital with completely different outcomes. One recovers steadily. The other develops complications, returns to the hospital, or never fully regains the independence they had before surgery. Doctors already consider age, frailty, chronic disease, and the complexity of the operation. But a large 2026 study suggests that another number may reveal hidden risk before the first incision is made. Not the age printed on a birth certificate. The biological age written inside a routine blood test. Researchers analyzed more than 430,000 surgical patients across the United Kingdom, the United States, and South Korea. They calculated a measure called PhenoAge, which estimates how old the body appears physiologically rather than how many years a person has lived. Patients whose bodies appeared to be aging faster faced higher risks of death, cardiovascular problems, hospital readmission, and immediate complications after surgery. The most striking comparison involved people the researchers classified as fast agers. Even after accounting for calendar age, frailty, existing diseases, physical status, and surgical complexity, fast agers had a 49% higher risk of dying within 1 year than normal agers. That does not mean a blood test can predict exactly what will happen to one individual. But it raises a question that could change how older adults are prepared for surgery. What if the most important age in the operating room is not the number of birthdays you have had, but how much physiological reserve your body still has? Surgery is a controlled injury. A surgeon may remove a tumor, repair a joint, replace a valve, or correct damaged tissue. But the body still experiences bleeding, inflammation, anesthesia, pain, temporary immobility, and a major demand for repair. A resilient body absorbs that shock and gradually returns to normal. A vulnerable body may look stable before the procedure but struggle once several systems are stressed at the same time. The lungs must maintain oxygen. The heart must adjust to changing blood pressure and fluid levels. The kidneys must process medications and waste. The immune system must defend against infection while controlling inflammation. Muscles must survive days of reduced movement. The brain must adapt to anesthesia, pain, disrupted sleep, and an unfamiliar environment. Recovery depends on all of these systems working together. That is why two people of the same age can have such different outcomes. Calendar age measures time. Biological age attempts to measure accumulated wear. The version used in the new study, called PhenoAge, does not require an expensive genetic test. It combines chronological age with 9 measurements commonly found in blood work. These include albumin, creatinine, glucose, C-reactive protein, alkaline phosphatase, several features of red and white blood cells, and the proportion of lymphocytes. No single measurement tells the whole story. Together, they provide a rough picture of inflammation, immune function, kidney health, liver-related processes, metabolism, and the condition of the blood. Think of it as reading the dashboard rather than looking only at the mileage. A car with 100,000 kilometers may be well-maintained and reliable. Another with the same mileage may have warning lights glowing across the panel. The number traveled is the same. The condition is not. The researchers first examined 291,845 surgical patients in the UK Biobank. For every additional year of PhenoAge, the odds of death within 1 year increased, even when the statistical model adjusted for many factors already used to estimate surgical risk. Biological age also predicted major cardiovascular events and readmission within 30 days. The team then tested the finding in 3 separate populations from the United States and South Korea. The same basic pattern appeared again. Finally, they evaluated patients prospectively at a large academic medical center. Biological age predicted complications occurring within the first 3 days after surgery. This replication matters. A result found in one hospital may reflect its patients, its surgical practices, or weaknesses in the dataset. Finding a similar relationship across countries, health systems, and patient populations makes the signal more convincing. But then comes the most important part. PhenoAge did not simply identify older patients. It separated people who shared the same chronological age. A person could be biologically younger than their calendar age and appear more resilient than expected. Another could be biologically older and carry hidden risk that conventional assessment might underestimate. This creates two possible benefits. The first is protection. A biologically older patient might need more detailed evaluation before surgery. The medical team could examine nutrition, physical function, medications, cognitive health, anemia, inflammation, blood sugar, and chronic disease more carefully. The second benefit is fairness. Calendar age alone can make an older adult appear too risky for a treatment that might improve or extend life. But an active, resilient 78-year-old may tolerate a complex procedure better than a physiologically vulnerable 62-year-old. A biological age measure could help doctors avoid treating every person over a certain age as though their bodies were identical. The goal is not to deny surgery to people with an older biological profile. It is to reveal who may need more preparation and support. That preparation is often called prehabilitation. Most people know rehabilitation as the work that begins after surgery. Prehabilitation moves part of that effort to the weeks before the operation. Depending on the patient and procedure, it may involve strength training, walking or aerobic exercise, breathing exercises, improved protein and calorie intake, smoking cessation, better blood sugar control, medication review, and psychological support. The principle is simple. Do not wait for the storm to begin before strengthening the house. Building even a small amount of reserve before surgery may help the body handle inflammation, immobility, and tissue repair more effectively. For an older adult, this reserve has practical meaning. It can mean standing up sooner, walking safely, avoiding prolonged weakness, returning home rather than needing extended institutional care, maintaining the ability to dress, bathe, cook, and move independently. These outcomes matter as much as surviving the operation itself. However, the new study did not test whether lowering PhenoAge before surgery improves recovery. It was an observational analysis. The researchers found that biological age predicted risk. They did not prove that changing the number would directly change the outcome. This distinction is critical. A high PhenoAge may reflect inflammation, poor metabolic health, kidney stress, malnutrition, chronic disease, or other problems that make surgery harder to tolerate. Improving those problems may reduce risk. But trying to manipulate the score without addressing the underlying health would miss the point. Biological age is a warning signal, not a diagnosis. It is also not a perfect measurement of the entire body. A person may have strong cardiovascular fitness but poor kidney function. Another may have excellent laboratory values while living with muscle weakness or early cognitive impairment. PhenoAge compresses several systems into one number. That makes it practical, but it also hides detail. A complete surgical assessment still needs information the blood test cannot provide. Can the patient climb stairs? Have they fallen recently? Are they losing weight unintentionally? Can they manage medication independently? Do they have memory problems? Do they have family or social support after discharge? What matters most to them if the operation succeeds, and what outcomes would they consider unacceptable? No aging clock can answer those questions. There is another risk. Consumer biological age tests are increasingly marketed as personal longevity scores. A result that says someone is biologically older can create fear, while a younger result can create false confidence. The 2026 surgical study does not prove that every commercial test accurately predicts surgical risk. It examined a specific blood-based measure in large clinical datasets. It also does not mean someone should calculate a score online and use it to decide whether to accept or reject an operation. Surgical decisions must consider the disease being treated, the consequences of doing nothing, available alternatives, and the person's goals. A high-risk operation may still be the best option. A low-risk score does not make any procedure harmless. The study is best understood as a step toward more personalized surgical medicine. Today, a doctor may see a 75-year-old patient and know that age raises risk on average. In the future, routine laboratory results may help reveal whether that particular patient resembles a typical 75-year-old, a more resilient 65-year-old, or a physiologically vulnerable 85-year-old. That information could influence how early preparation begins, how aggressively chronic conditions are optimized, what type of anesthesia is considered, how closely the patient is monitored, and what recovery support is arranged before they leave the hospital. It could also identify people who appear healthy during a short clinic visit but have less reserve than expected. The deeper lesson is that aging is not distributed evenly. The calendar moves at the same speed for everyone. The body does not. Years of sleep, movement, nutrition, illness, stress, smoking, alcohol exposure, medications, genetics, environment, and access to healthcare leave different patterns inside each person. Surgery exposes those differences because it demands that multiple systems respond at once. For someone expecting an operation, the practical message is not to chase a younger biological age number. It is to ask better questions. Should my nutrition or protein intake be evaluated? Would supervised exercise or physical therapy before surgery help? Are my blood sugar, anemia, blood pressure, kidney function, and medications optimized? Should my memory, mobility, or frailty be assessed? What support will I need during the first days and weeks after discharge? The answers will depend on the operation and the individual. Some surgeries are urgent and leave little time for preparation. Exercise or dietary changes may also be unsafe for certain patients without medical guidance. But when time is available, the period before surgery should not be treated as empty waiting. It may be part of the treatment. The new research does not show that we can stop aging before an operation. It shows that the body carries a record of aging that may help predict how well it will withstand the challenge. Two patients may enter the hospital with the same birthday. Their bodies may be arriving at very different ages.